Welcome to the Deep Dive. We take the info you give us, boil it down, and get you up to speed fast.
Yep, giving you the key insights without the fluff.
Exactly. And today, we're diving into Sjogren syndrome, based on those revision notes you sent over.
Right. The goal is high-yield info for revision. Clear, concise.
We'll cover the definition, causes, risks, how it works, what else it might look like, who gets it.
How it shows up, diagnosis, management, the outlook, complications, the whole picture.
Okay, let's start unpacking Sjogren's then. What exactly is it?
Okay, so fundamentally, Sjogren syndrome is a chronic autoimmune disorder.
Autoimmune, meaning the body attacks itself.
Precisely. Your immune system gets confused and attacks healthy tissues. Here, it primarily targets the glands that produce moisture, so salivary glands in the mouth.
Leading to dry mouth.
Right. And the lacrimal glands in the eyes.
Causing dry eyes.
Yeah, those are the key features. But it's important to remember it can be systemic too. It can affect other organs.
Ah, so not just dryness.
Not always, no. And we also distinguish between primary Sjogren's, where it happens on its own, and secondary Sjogren's.
Secondary meaning it's linked to something else.
Exactly. It develops alongside other autoimmune conditions. Things like rheumatoid arthritis, scleroderma, lupus,
And does that happen straight away?
Often not. Typically, secondary Sjogren's might develop, say, 10 years after the first autoimmune condition started.
Interesting. And the notes flagged up a big gender difference.
Oh, definitely. It's much, much more common in females. The ratio is something like 9 women for every 1 man affected. Really quite striking.
Okay, 9-1. Got it.
Yeah.
So why does this happen? What are the causes, the etiology? The note said it's a bit of a mystery.
Well, yeah, the exact cause isn't fully pinned down. It seems to be a combination. Like many autoimmune diseases, genetics plays a part.
So it runs in families sometimes.
It can, yeah. There's a genetic predisposition. But then you need environmental triggers, too.
Like what sort of triggers?
That's the less clear part. Researchers are looking at things like maybe viral infections or exposure to certain environmental factors. It's like the genes load the gun and the environment pulls the trigger.
Makes sense.
And the underlying mechanism is that immune attack on the moisture glands we mentioned. Inflammation, reduced function.
The notes also mentioned CREST syndrome. How does that fit in?
Right, CREST. It's actually a type of scleroderma, a limited form. The acronym stands for calcinosis, Raynaud's, esophageal dysmotility, sclerodactyly, and telangiectasia.
Okay.
Seeing it mentioned just highlights how these autoimmune conditions can overlap, share some features or pathways.
And other common issues mentioned were things like joint pain.
Yes, joint pain, swelling, fatigue, those are very common in Sjogren's patients. And there's also a link noted with recurrent miscarriage, specifically in women who also have antiphospholipid syndrome. That's another autoimmune issue affecting blood clotting.
So if someone's thinking about risk, what are the main factors? Who's more likely to develop Sjogren's?
Okay, well, the biggest risk factor, as we said, is being female.
By far.
Yeah. Age is another factor. The peak time for diagnosis is usually between 40 and 60.
Middle age, mostly.
Mostly, yeah. A family history of any autoimmune disease also bumps up the risk.
Not just Sjogren's specifically.
No, any autoimmune condition in the family. And then there are specific gene variations that we know are involved, though research is still ongoing to identify them all precisely.
And the triggers. Still looking into those.
Still investigating potential infections or environmental exposures that might kickstart the process in someone who's genetically susceptible. It's like a puzzle we're still piecing together.
Okay. So let's get into the nuts and bolts, the pathophysiology. How does the immune attack actually cause the dryness and other problems?
Right. So imagine your salivary and lacrimal glands are little factories. In Sjogren's, immune cells, mainly lymphocytes, like foot soldiers of the immune system, infiltrate these factories.
They invade the glands.
Exactly. This causes chronic inflammation, and over time, this inflammation damages and destroys the gland tissue itself.
So the factories get damaged and can't produce as much.
Precisely. The direct result is less tear production, less saliva production, hence the dry eyes and dry mouth.
Classic symptoms.
Classic symptoms. But, as we mentioned, this inflammatory process isn't always confined to the glands. It can spread, potentially affecting lungs, kidneys, joints, causing those broader systemic issues.
Okay. Now, someone comes in with dry eyes, dry mouth. Seems straightforward, But the notes listed a lot of differential diagnoses. Why so many possibilities?
That's a really crucial point. Dryness or SICCA symptoms is common. It can be caused by many things, not just Sjogren, so you absolutely have to rule out other conditions.
Makes sense. What sort of things are on that list?
Well, the notes give a good overview. You've got things like amyloidosis, which involves abnormal protein deposits.
Okay.
Bulimia, because vomiting can affect salivary glands. Chronic pancreatitis sometimes presents with dryness. Graft versus host disease, post-transplant.
Right. And there are the other autoimmune conditions that can overlap or cause secondary Sjogren's, polymyositis, rheumatoid arthritis, scleroderma, lupus. We need to differentiate.
Lots of overlap there.
Definitely.
Yeah.
Plus, more localized things like salivary gland tumors or infections like TB. Sarcoidosis is another inflammatory condition to consider.
Okay.
And finally, there's something called non-Sjogren SICCA syndrome. That's where you have the dryness, but not the specific autoimmune markers of Sjogren's. So working through that list is key to getting the right diagnosis.
Let's talk numbers then, epidemiology. Who gets Sjogren's and where?
Okay. In the UK, the prevalence is estimated around 0.1 to 0.2%. Not super common, but not rare either.
And primarily women.
Overwhelmingly.
Okay.
We mentioned the 9.1 or even higher ratios, and typically diagnosed in middle age, 40s to 60s, although it can occur at any age.
Is it similar worldwide?
Broadly, yes. Global estimates for primary Sjogren's are around 61 per 100,000. Rates seem highest in Europe. The average age at diagnosis is about 56.
But you mentioned another peak. Yeah, there's a smaller peak sometimes seen in younger adults, maybe between 20 and 40. And a really important point is that symptoms often start years before diagnosis. People live with it for a while.
Right, the diagnosis lags behind the symptoms.
Often, yes.
Okay, so we know who's at risk, what's happening inside. What does it actually look like when someone presents? What are the clinical features to watch for?
It can look quite different from person to person, which adds to the diagnostic challenge. But the most common things, the absolute hallmarks, are the dry eyes, xerothalmia.
Which feels like grit or burning.
Exactly. A gritty, sandy, burning feeling. And dry mouth xerostomia.
Making it hard to talk or swallow.
Yes. Difficulty speaking, swallowing, chewing sometimes.
Yeah.
And a big increase in dental cavities or decay is a major consequence.
Okay, dryness is key. What else?
Fatigue is huge. Patients often report really debilitating fatigue. Joint pain, arthralgia is also very common. Skin rashes can occur.
Any other notable features?
Definitely. Vaginal dryness is common in women. Muscle aches, myalgia. Raynaud's phenomenon, where fingers and toes change color in the cold.
Right, I've heard of that.
Sensory polyneuropathy, nerve issues causing tingling or numbness, usually in the hands or feet. And sometimes recurrent swelling of the parotid glands, the big salivary glands by the ears.
Parasitis.
Correct. The notes also mention renal tubular acidosis, but that's often subclinical, so not causing obvious symptoms day to day.
So how common are these main symptoms?
Well, the SICCA symptoms, dry eyes and mouth together, are present in almost everyone, up to 98%. Xerostomia leads to those speaking-aiding issues and the high risk of dental caries and oral candida, or thrush.
Okay.
Parotid swelling happens in maybe up to a third of patients. Joint pain or non-erosive arthritis affects around half.
And the systemic stuff, lungs, kidneys?
Yeah, lung involvement, like interstitial lung disease, is seen in maybe 9–12%. Skin vasculitis in about 10%. Kidney changes, typically tubulointerstitial, around 5%. And peripheral nerve issues in 10–25%.
Quite a range.
It really is. And a critical point for counseling. Women positive for anti-RASA and anti-LAS-SB antibodies have a risk of their baby developing congenital heart block during pregnancy. That needs careful management.
That's really important to know.
Absolutely. And another serious point is the increased risk of lymphoma, specifically B-cell lymphoma. The lifetime risk is estimated at 5–10% for people with Sjogren's.
Wow, that's significant.
It is. And finally, there are strong associations with other autoimmune conditions, thyroid disease, celiac disease, primary biliary cirrhosis, various types of arthritis, lupus-like skin conditions, low platelets. It's a complex picture of potential associations.
Okay, so given that wide range of symptoms and associations, how do you actually confirm a diagnosis? What investigations are used?
It's really about putting pieces together, clinical picture plus tests. Blood tests are crucial.
What are you looking for in the blood?
We look for rheumatoid factor, REF, which is positive in about half. Anti-nuclear antibodies, ANA, positive in maybe 70%.
Yep.
Then the more specific ones for Sjogren's. Anti-Ro, also called SSA, is positive in around 70% of primary Sjogren's, and anti-La, or SSB, in about 30% of primary cases.
So those antibodies are key markers.
Very key. You might also see generally high levels of antibodies, hypergammaglobulinemia, and sometimes low levels of a complement protein called C4.
Right. What about checking the gland function directly?
Yes, that's important too. The Schirmer's test measures tear production, a strip of filter paper in the lower eyelid. Less than 5 millimeters of wetting in 5 minutes suggests significant dryness.
Simple but effective.
Yeah. Imaging can also help. Salivary gland ultrasound is increasingly used. It's non-invasive and can show typical changes.
Okay.
In trickier cases, maybe silography and X-ray with dye or salivary scintigraphy and nuclear scan. CT might be used if there's concern about lymphoma, and MRI can show chronic gland inflammation.
And biopsy.
Yes, a minor salivary gland biopsy, usually a tiny sample taken from the inside of the lip, is often done. They look for characteristic clusters of lymphocytes infiltrating the gland tissue.
So looking for direct evidence of that immune attachment.
Exactly. Sometimes kidney function tests, like creatinine clearance, might be reduced too.
Are there specific criteria for diagnosis?
Yes, there are internationally agreed criteria, the ACR-EULAR criteria. They combine several findings. The lip biopsy result being positive for anti-SRO antibodies, objective eye tests like staining scores or the Schirmer's test result, and measured unstimulated saliva flow rate. You need a certain number of these to meet the criteria.
So it's a combination of clinical signs, blood tests, and functional tests.
Precisely.
Mm-hmm.
And always involves considering the patient's symptoms and ruling out those other conditions we discussed.
Okay, so a diagnosis is made. What then? How is Sjogren's managed? Is there a cure?
Unfortunately, there's no cure currently, so management is all about relieving the symptoms and preventing or managing complications.
Symptom control is key.
Absolutely. Artificial tears for the eyes and saliva substitutes or stimulants for the mouth are really the cornerstones, just replacing the moisture that's missing.
Makes sense. What else?
Excellent oral hygiene is non-negotiable. Regular dental visits, fluoride, careful cleaning. It's vital to prevent cavities and infections.
Because the lack of saliva increases risk so much.
Massively. Medications might be used for inflammation or other symptoms like joint pain. Lifestyle adjustments can help with fatigue. And because it can be systemic, ongoing monitoring by a rheumatologist is really important.
What about specific treatments?
For eyes, besides frequent artificial tears, maybe gels or ointments at night, humidifiers can help. Special glasses that create a moisture chamber around the eyes. And in some cases, punctal plugs, tiny plugs put in the tear ducts to stop tears draining away too quickly.
Keeping the tears you do have around for longer.
Exactly. For the mouth, sipping water frequently using artificial saliva sprays or gels. Sometimes a drug called pilocarpine can be prescribed to stimulate the salivary glands to produce more saliva.
Does that work well?
It can help some people, but it has side effects. And again, meticulous dental care, antiseptic mouthwashes sometimes.
And for the more systemic side?
Yeah.
Or severe cases?
If there's significant joint pain or skin issues, hydroxychloroquine is often used. It's an anti-malarial drug that also helps with autoimmune inflammation. For more severe systemic involvement, stronger immunosuppressants might be needed. And in refractory, severe systemic cases, a biologic drug called rituximab, which targets B cells, might be considered.
So there are options depending on severity.
Yes. Doctors use scoring systems like ESPRI for patient symptoms and ESDI for disease activity to track things. And it's generally wise to avoid medications that can worsen dryness, like certain antihistamines or antidepressants, anticholinergics.
Good point. What about other dryness, like vaginal dryness?
The vaginal lubricants are recommended, and it's important to watch for and treat vaginal yeast infections, which can be more common. Emollients help with dry skin.
Okay, very symptom-focused approach overall.
Primarily, yes, managing the impact day to day.
So what's the long-term picture? What's the prognosis for someone living with Sjogren's?
It really varies quite a lot. It depends heavily on which organs, if any, become involved beyond the glands and if serious complications develop.
So it's not the same for everyone.
Not at all. Many people manage well with symptomatic treatments and lifestyle changes and lead relatively normal lives.
Yeah.
But those with severe disease, especially with significant organ involvement, will need more intensive ongoing care.
Does it impact quality of life?
Oh, definitely. The range of symptoms, the dryness, fatigue, pain can significantly impact quality of life, even if the condition isn't life-threatening for most.
Are there particular concerns regarding mortality?
The main causes of death that are slightly increased compared to the general population tend to be cardiovascular disease, infections, sometimes tumors, and importantly, that increased risk of lymphoma we mentioned.
Right.
And for secondary Sjogren's, the prognosis is often closely linked to the outlook for the primary autoimmune condition, like the lupus or rheumatoid arthritis.
Okay. And finally, what are the main complications to be aware of? What can go wrong down the line?
Well, the direct consequence of dryness is damage. Eye damage like corneal ulcers, severe dental decay, and tooth loss. Recurrent mouth infections like thrush. Damage to other mucous membranes.
So managing dryness is key to preventing that.
Absolutely. There's also that increased susceptibility to infections generally in the dry areas. Joint and muscle pain can be persistent problems.
And the organ involvement.
Yes, potential complications involving the lungs, kidneys, liver, skin, nerves. That needs monitoring.
And the big one, lymphoma.
Yes, the significantly elevated risk of non-Hodgkin's lymphoma is probably the most serious potential complication, and also, rarely, tumors can develop in the persistently swollen parotid glands, so that needs watching too. Plus, the potential development of other associated autoimmune conditions over time.
It's certainly a condition with many facets.
It really is. Requires careful, ongoing management.
So wrapping this up then, Sjogren's syndrome.
Yeah.
It's a chronic autoimmune condition, hits the moisture glands hardest, causing dryness, but definitely has the potential to go systemic.
Yeah, and the presentation can be really varied, which makes diagnosis sometimes tricky and management very individualized.
Recognizing all those possible features, from dryness to fatigue to organ issues, is key, and it needs that joined-up, multidisciplinary care.
Definitely. And, understanding how the immune system goes awry in Sjogren's can actually teach us a lot about other autoimmune diseases, too. It highlights the complexity of our own immune responses.
That's a great point, thinking about the bigger picture. Okay, if you want to keep digging into Sjogren's or revise other conditions, remember to check out passthemsrai.com and freemsra.com.
Great resources there.
Thanks for joining us on this deep dive.